So now that we have completed our part 1 and part 2, the probable difficult topics, we have been able to form a vision of the pathways, everybody. And I hope we have got some confidence. We move on to our third subtopic in neuro-ophthalmology, the easier topic, the theoretical topic, the non-pathway topic, so as to say the non-neuro topic, yes? And the name of the topic is, everybody, optic atrophy. As the name itself makes it very clear, atrophy of the optic nerve. That is what we are talking about. So now the question comes into mind, what causes atrophy of the optic nerve? So any disease which can affect optic nerve, let's say optic neuritis, a name we have heard. Let's say hereditary optic neuropathy, toxic optic neuropathy, all these names we have heard previously. So any disease of the optic nerve, if left untreated, will ultimately lead to atrophy of the neural tissue or optic atrophy. I hope we are very clear about this. Now, let's move on to the fact of how to identify when we are looking at an optic disc that if it is a normal optic nerve or a case of optic atrophy. So we are essentially asking, what are the signs of optic atrophy? So the most important sign of optic atrophy is that there is pallor of optic disc. So optic disc is usually pinkish or orangish in color. Here it becomes pale because of the loss of vasculature, everybody. We say the optic disc becomes pale in color, pale pink, very pale yellow, very pale orange, something like that, everybody. That is almost the diagnostic sign when you're looking at the optic disc. The second important thing that we know is something called as Kestenbaum index. So when we look at an image of the optic nerve, as I will show you on the screen now, we can see two types of blood vessels, everybody. Marking with blue color, these are my large vessels. This can be an artery, a vein, an arteriole or a venule. Yes? Or there can be small blood vessels, which are marked with these white arrows, which I am now coloring yellow. Can you see, everybody? These very small blood vessels, which cannot be classified either as an artery, vein, venule, anything, everybody. Yes? So what we do is, in Kestenbaum's index, we count the number of small blood vessels. In optic atrophy, there is a loss of small blood vessels. So we say normal small blood vessels are 7 to 10. But in cases of optic atrophy, they become less than 7. Yes? So if we count these small blood vessels, everybody, in the image, everybody, we will be able to see 1. I hope you are able to see very faint small blood vessel. We are able to see 2, a second blood vessel. We are able to see number 3, number 4, number 5, and number 6. So we are able to see 6 small blood vessels, which leads us to a probable diagnosis of optic atrophy, everybody. Yes? And that is Kestenbaum's index. Lastly, remember that the visual loss in optic atrophy does not correlate. That means the amount of visual loss is usually lesser than the amount of optic atrophy seen. Why is that so? Because optic nerve is a collection of nerve fibers coming from all over the retina. What if optic atrophy is occurring but the macular fibers are not getting affected as yet? So our central vision, the vision we usually test in Snellen's chart testing or anything else, remains unaffected, and still we see a lot of optic atrophy going on. The same thing is there in glaucoma, everybody. When we read glaucoma, or if you have read glaucoma, glaucoma causes optic atrophy. But it affects the peripheral nerve fibers, the peripheral visual field first. So the central vision remains a lot till the end, even though we are able to see a lot of glaucomatous optic atrophy happening, everybody. Yes? So this is our diagnosis of optic atrophy. Now, moving on. What are the types of optic atrophy? So as listed on the screen for you, we can divide optic atrophy, guys, into 3 types. Primary optic atrophy, secondary optic atrophy, and consecutive. Now, if you are smart, which you are, you know what is a primary disease and a secondary disease, guys. Yes, that is basic nomenclature in medicine, everybody. Primary means a disease which is occurring by itself. Secondary means a disease which is occurring due to some already existing pathology or disease. Yes. So based on that, we can easily learn what is primary optic atrophy and what is secondary optic atrophy. So let's see everybody. Primary optic atrophy. Optic atrophy without any antecedent optic disc swelling. So what are we essentially trying to say here? We are trying to say that before today, antecedent, previously, before today, whenever we looked at the optic disc, it was normal. Why are we saying optic disc? Because as we remember through anatomy, everybody in neuro-ophthalmology part 1 video, optic disc is the only visible part of the optic nerve. Yes, everybody? Yes? So, whenever we wanted to examine the optic nerve before today, we looked at the optic disc and we found that the optic disc was absolutely normal. So, we said that straight away we have started seeing changes of optic atrophy without any previous disease in the optic nerve or the optic disc, and that is why we are calling it primary. Am I absolutely clear? Now, let us see what is secondary optic atrophy. Secondary again due to some other cause. So, optic atrophy due to existing optic disc swelling. Okay. So optic atrophy which is occurring after optic disc swelling due to some existing optic disc swelling. So very clear definition everybody, telling us that before today there was some disease which led to the optic disc swelling and because of that optic atrophy has occurred. Am I absolutely clear? So the key word is we are able to see optic disc swelling in this and only after that optic atrophy sets in. Primary and secondary are very easy to understand. Now, what do we mean by the third variety, everybody? The third variety is an English word which we are calling consecutive optic atrophy. So, what is the meaning of the word consecutive? See, English, MBBS is half English, everybody, yes? So, consecutive means what? Consecutive means one after the other. If there are 3 students sitting on a desk, everybody, I can say student number 1 is consecutive to number 2 is consecutive to number 3. One after the other. So, what are we trying to say? This is my retina, everybody. I hope you remember. This is my retina. This is my optic nerve. Yes? So, first of all, there was a disease in the retina. And then consecutively, it has affected your optic disc or your optic nerve. So, first in the retina, then the disease jumps onto the consecutive student or the consecutive structure, that is the optic nerve. So, one after the other. So, what does it tell us? It tells us that consecutive optic atrophy is occurring due to some disease, but that disease was not in the optic nerve, it was in the retina. So, what does the definition become? Optic atrophy due to diseases of inner retina and its blood supply. Inner retina, that's the word. Okay, so if I summarize this for you, primary means no problem before today, secondary means problem in the optic disc, and consecutive means problem in the retina. I hope we are pretty clear about the meaning of the primary, secondary and the consecutive optic atrophy. Now, how to differentiate between the fact that it is primary, secondary or consecutive, everybody? We look at the color of the optic disc. Color of the optic disc in primary becomes whitish, or I can say pale yellow. Diagnostic. Okay, let us see the image, everybody. When we see this image, everybody, what do we see? We are able to see the optic nerve, optic disc. Is there any pinkish or is there any orangish color here? No, it is a pale yellow or a whitish optic disc. Clearly a case of primary optic atrophy. I hope nobody has any confusion in this image. Very simple image. Moving back, everybody, secondary optic atrophy. The color of the optic disc in secondary optic atrophy is said to be dirty gray. Dirty gray, we are not sure of the color. What is important is this word, blurring of disc margins. Again, guys, if you are smart enough, you are already able to understand why is this important, everybody. Because in the definition, we have written that secondary optic atrophy is due to one word, that is swelling. If the optic disc becomes swollen, its margins will become blurred like everywhere else with any structure, everybody. Yes. So let us see the image. Let us try to understand this in very simple words, everybody. Let us see this image. Yes. In this image, if we try to see carefully, everybody, we are able to see the disc margins here, everybody. But in this area, everybody, we see that due to the ensuing peripapillary edema, everybody, that around the optic disc the swelling has started to occur, the margins have become blurred. They are not as crisp as if I go back to primary optic atrophy. Everybody compare the photo at the top and the bottom. The margins are crisp, clear, everybody, whereas in secondary optic atrophy, the margins have become blurred. And that is how we are able to understand whether we are looking at a case of primary and secondary optic atrophy, obviously along with the history that we have from the previous checkups of the patient. What about consecutive optic atrophy, guys? So consecutive optic atrophy, we say waxy pale optic disc. Okay, theoretical question based on image. Very seldom we are able to diagnose it, but diagnosis is easy because we already know that there is a disease in the retina occurring. Everybody, we know the signs and symptoms of those diseases, and thus it becomes an extension of that, everybody. So actually, we don't need the photograph to be able to diagnose consecutive optic atrophy. As far as image-based questions go, you need to remember the difference between primary and secondary optic atrophy. Right, guys? Now that we have been able to differentiate, the question comes into our mind: why are we differentiating? Because based on the condition, there have to be different causes of primary, secondary, or consecutive. So that is what we move on to. What are the causes, everybody? Okay. So causes of primary optic atrophy. The first important cause is optic neuritis. Okay. All of us know, again through previously taught topics, that the most common cause of optic neuritis is multiple sclerosis. So in the question, you can find any of the two options, either optic neuritis or multiple sclerosis. The examiners are trying to ask you primary optic atrophy in both these cases, everybody. Second, in cases of trauma. Thirdly, in cases of any tumor. Fourthly, in cases of any toxic agent, everybody. Toxic agent leading to optic atrophy. Sudden, everybody. Yes. And lastly, everybody, if it is hereditary. Hereditary disease, no signs and symptoms before, straight away leading to primary optic atrophy. Am I absolutely clear here, everybody? Yes? Now, let's move on to the causes of the secondary optic atrophy. In secondary optic atrophy, we have said that there needs to be some cause. What kind of cause? Papilledema. From the name itself, it is very clear. Papilledema, edema of the optic disc. Number 2, everybody. Papillitis. Papillitis, itis means inflammation, papilla means optic disc, inflammation of optic disc. And number 3, a condition known as AION, which we'll discuss in detail later, which you have already heard the name in altitudinal visual field defects as anterior ischemic optic neuropathy. Now, moving on to consecutive, everybody. Even if I don't list it, you are smart enough to be able to learn this, I hope, because we have written that it is due to diseases of inner retina. So all the diseases of retina and its blood supply should come under the list. But still, if I want to make a list, I will say very important cause, a disease called as retinitis pigmentosa, or vascular conditions like CRAO, CRVO, that is central retinal artery occlusion, central retinal vein occlusion, everybody. Yes. So this is a complete list of what is the type of optic atrophy, how to be able to distinguish them theoretically on image based and the different causes. Right, guys? I hope we are clear with the small topic optic atrophy. But now to complete the topic optic atrophy, everybody, we have a list of topics here that we can study in detail. So we will be starting with the first important topic, everybody, optic neuritis. We will be moving on to toxic optic neuropathy, hereditary optic neuropathy, papilledema, and we will end our discussion with AION. So some of the diseases of the optic nerve which are in effect causing optic atrophy. Okay. So let's start, everybody, with optic neuritis. Now, the definition is pretty clear. The name makes it clear, everybody. Optic neuritis. Itis means inflammation, neuro means nerve, optic nerve. Yes, so we are talking about the inflammation of optic nerve. Now, Optic neuritis can be divided into three subtypes or three types, everybody. Now, the three types as listed on the screen can be number 1, papillitis, number 2, retrobulbar neuritis, and number 3, neuroretinitis. These are the three names. Now, how to differentiate between these three, or what is papillitis, what is retrobulbar, and what is neuroretinitis? Yes. So, we can define them based on inflammation of which part of optic nerve. What do I mean to say? If you have missed part 1 of neuro-ophthalmology, go back. I had discussed the brief anatomy of optic nerve there, in which we had read that optic nerve can be divided into 4 parts. The first part was the intraocular part, the shortest part, known as optic disc. That's what I have written here. Inflammation of optic disc, or the first part, and inflammation of the second, the third, or the fourth part. So we are saying either the inflammation of the intraocular part, that is the optic disc, or inflammation of the rest of the optic nerve. The second part, the intraorbital, the third part, the intracanalicular, and the fourth part, the intracranial. Okay. Now, papillitis. When I say papillitis, again and again I have mentioned previously in the past 2 minutes, papilla means optic disc. Papillitis, by the name itself, is making itself very clear that I am inflammation of only the optic disc, not of any other part. Am I clear here, everybody? Yes? Now, second part, retrobulbar. Again, if you focus on the English, everybody, it is very easy. Retro means previous, behind. Bulbar means eye, everybody. Behind the eye. This is my eyeball, this is my retina, this is my optic nerve. Again, everybody, look at my hand. So you can see the optic disc, this is the intraocular part. But all this part, everybody, that is behind the eyeball, that is getting inflamed. That means the optic disc is not getting inflamed. Intraocular part, no. Retrobulbar, all the other parts, second part, third part, and fourth part of the optic nerve are getting inflamed. Am I clear here, everybody? Now, the last subtype, everybody, the last subtype is neuroretinitis. Neuroretinitis is inflammation of the optic disc, or the intraocular part, plus inflammation of macula. So it is different from papillitis in the fact that papillitis is only inflammation of the optic disc, but neuroretinitis is inflammation of the optic disc along with macula, everybody. Yes. So these are the three subtypes, we can say, of optic neuritis. Now, papillitis as a condition is most common in children. Please remember, this is a manifestation which is the most common in children. Along with the inflammation, we see hyperemia or congestion of the optic disc. Okay, everybody? Now, retrobulbar neuritis. The name we already understand. We already understand that it is inflammation behind the optic nerve. So, patient is suffering from visual loss. Yes. And I, as a doctor, when I try to examine the optic nerve, everybody, of the patient, I will end up saying that the optic disc looks within normal limits, or it looks normal. I can't see anything behind the optic disc. Again and again I specify the only visible part of the optic nerve is the optic disc. So we end up saying in this case, patient and doctor both can't see anything. I hope you understand what I'm trying to explain you in retrobulbar neuritis. The patient can't see anything because the patient has disease. The doctor can't see anything in the eye of the patient because the optic disc is absolutely normal. This condition is most common in adults. Retrobulbar neuritis is most common in adults. Am I absolutely clear? Now, neuroretinitis, everybody. Neuroretinitis, as I have said, differs from papillitis because there is inflammation of macula also, and due to that fact, we get something called as the macular star appearance. At the macula, due to the edema, exudates get deposited. Exudates are lipid deposits, everybody, yellowish in color. As we can see in the ensuing images, everybody, this is my optic disc, which I hope you can make out that there is some swelling, everybody. This area is my macula. Around the macula, you can see yellowish. I'll just mark them right. These yellowish deposits which are starting to form in kind of a star, everybody, appearance. When we make a star, everybody, we tend to make sun is a star, everybody. We tend to make light like this, everybody. Yes. So this is what it is starting from. Slowly it will complete in 360-degree. This is in one eye and this is in the other eye. Again, you can see macular star starting to form, everybody. Yes. So this is a very important diagnostic sign in cases of neuroretinitis along with the inflammation of the optic disc. Now, macular star is an important word. Questions are asked on this. The image I have already shown you. If it is an image-based question, they can ask you what are the causes of macular star appearance. So apart from neuroretinitis, everybody, there are some other causes. The other causes as listed, number one, very important cause, hypertensive retinopathy, changes in the retina due to hypertension, papilledema, edema of the optic disc, which we will read further, and retinal angioma. So these are the four important causes we can say of a case of macular star appearance. These are the types of optic neuritis for you. Now, let's say we have been able to diagnose the type of optic neuritis. But what about the clinical features of the presentation of a case of optic neuritis? So now let's see the presentation or the clinical features of a case of optic neuritis. Whatever we may be talking about, papillitis, retrobulbar neuritis or neuroretinitis. We can remember these clinical features through a mnemonic, everybody. I will write the clinical features and along with that the mnemonic will form. C for the patient suffers from a visual field defect which we know is central scotoma. Again, neuropathy part 1 we had read the causes of central scotoma, everybody. Then C, everybody, the patient suffers from color blindness. Most commonly red and green color blindness. Then everybody, U, very, very, very important diagnostic sign. The patient has unilateral visual loss. And this visual loss is usually sudden and painless. The patient will say suddenly over a period of probably the last 24 hours, I have started to see very less and very blurred in one of the eyes only. Unilaterality is what should lead you towards the differential diagnosis if mentioned in a question. Bilateral optic neuritis, forget it. Unilateral, always think about it. Okay. Then U for Uthoff sign. This you may have also read in medicine, everybody. Uthoff sign, a sign of multiple sclerosis. I have mentioned again and again that the most common cause of optic neuritis is multiple sclerosis. So multiple sclerosis leading to optic neuritis, you will see Uthoff sign also. What is Uthoff sign, everybody? Exacerbation on increased body temperature. P for another important sign, which is Pulfrich sign. Pulfrich sign is that kinetic objects perception is affected. The perception of the kinetic objects gets affected, everybody. Then lastly, P, pain on movement of eye. Now, this is a point which usually confuses students. I have written in point number 3 that the visual loss is painless, but here I am writing pain on movement of eye. What are we trying to say? We are trying to say that along with the visual loss, there is no pain. The patient is not saying that my eye is having severe pain. If my eyes are closed, they are not moving, I don't have any pain, I have visual loss. Yes, I have visual loss. But if the patient is moving eyes up, down, left, right, everybody, then the patient says along with the movement of the eye, I experience some pain. Why is that so? It is so because in the intracanalicular part, everybody, the sheath, the pial sheath, everybody, of the optic nerve is fused with the sheath of the superior rectus and other extraocular muscles. If we remember, everybody, the annulus ring, everybody, yes, the tendinous ring, everybody, where from all the extraocular muscles originate, everybody, the annulus ring of Zinn, everybody. So due to that fusion of the pial sheath, whenever there is movement, everybody, Because along with the inflammation of the optic nerve, some of the muscles are also inflamed. So whenever there is movement, the extraocular muscles are used, and that is why it leads to pain on ocular movement. I hope we are able to understand this. Lastly, everybody, I am writing 3 letters MAR, and I am writing Marcus Gunn pupil, which we have read in part 2, everybody, also known as RAPD. Please remember, this is the earliest presentation or the earliest sign which can lead to the diagnosis of a case of optic neuritis, everybody. Yes? Now, if we have understood all of this, everybody, there are 2 keywords here, everybody. Please remember RAPD as the earliest sign, and please remember unilaterality along with all the other features, everybody, that you can test. The mnemonic, if we see, everybody, becomes 2 C's, 2 U's, 2 P's, and MAR. So I remember it like CUP, cup, mar. Do cup mar. Hit me with 2 cups, basically. Yes or no? So if we make a literal English of it, very simple Hindi, everybody. Do cup mar. 2 cup mar. Okay, everybody. So that's how I remember 2C, 2U, 2P, and MAR for Marcus Gunn pupil. These are the important clinical features of a case of optic neuritis, everybody. A common case to present in your clinical practice. Now, if we know optic neuritis is developing, or if we have diagnosed a case of optic neuritis, obviously we need to treat it. Why do we need to treat it? We need to treat because it is causing visual loss, as simple as that. So, treatment number 1, there was a trial which was done, which was called as optic neuritis treatment trial, everybody. Under this, it was postulated that intravenous methylprednisolone 1 gram daily into 3 days, followed by oral prednisolone 1 mg per kg per day for 11 days. This is the treatment which should be given according to ONTT, optic neuritis treatment trial. Okay. What does this treatment do? This treatment is supposed to fasten the recovery. So we say the recovery time is fast. Okay, everybody. It is supposed to reduce the recurrence. So we say the recurrent episodes are reduced. But everybody, final visual outcome not affected. What do I mean to say by point number 3? That even without treatment, everybody, optic neuritis starts to recover in 2 to 3 weeks. Let's say visual loss had occurred and visual recovery had to come back to 6/12. The treatment is not going to make you achieve 6/6. The final visual outcome is not affected, everybody. Only the recovery time will be quickened, everybody. So instead of 2 to 3 weeks or maybe 6 weeks, you will be able to regain the vision back in, let's say, 1 week or 2 weeks max, everybody. So that is the basic fundamental that you need to remember. You are not doing it to improve the prognosis. You are doing it to just fasten the recovery, everybody. Okay. Please remember, very important point which I am writing. Only oral steroids should not be given, as they increase chances of recurrence. Again, through studies done, it has been found out that if ONTT is not followed in entirety, if we straight away start with oral prednisolone and we only give oral prednisolone, this is what occurs, everybody. Yes? No confusion? ONTT trial should be started if visual loss less than 6/12. That means if you have lost more vision. So if you are 6/12 or 6/9, we don't give treatment, everybody. Secondly, previous episode of optic neuritis or multiple sclerosis, and at least one lesion That means demyelinating lesion on MRI. Okay, everybody. If only these criteria are fulfilled, then we start with ONTT. That is the steroid treatment that we have just explained. Okay. So apart from the steroid, do we have any other treatment option for optic neuritis? Yes, we have, everybody. So number 2, there was another study called as CHAMPS trial or CHAMPS study done, which advocated the use of beta interferon 1A to reduce chances of MS after optic neuritis. If you have optic neuritis, you can have MS. If you have MS, you can have optic neuritis. Two-way street, everybody. So reduce the chances of MS post optic neuritis. Beta interferon 1A can be given. Or lastly, a drug can be given, glatiramir acetate. 20 milligrams subcutaneous injection. Okay, everybody. These are the 3 treatment options we have. Usually ONTT trial is followed, everybody. The steroid treatment is followed for the treatment of optic neuritis. I hope all of us are clear with the optic neuritis, the types, the treatment, the clinical features, an important subtopic of a subtopic, that is optic atrophy. Next, we start with our next condition, that is hereditary optic neuropathy. So now let's start with our next topic, everybody, under optic atrophy, that is hereditary optic neuropathy. As the name itself clarifies, everybody, optic neuropathy means optic nerve disease and hereditary means something which is inherited. Yes? So there are some 4 types of hereditary optic neuropathy. Let's name them, everybody. So the first name is Jare. I know. The second name is Bear. Again, I know. The third name is Wolfram. And then the last name you may have heard, Leber's. LHON, Leber hereditary optic neuropathy. If you have a strong biochemistry, everybody, then you may have heard this name. Why? Because in hereditary diseases, the first question that we end up asking you is, what is the mode of inheritance? So the mode of inheritance in Jare is autosomal dominant. In Bear and Wolfram is autosomal recessive. And in Leber, everybody, that is where your biochemistry knowledge comes in. Anybody? Yes? Yes, everybody. The inheritance is mitochondrial. It is a mitochondrially inherited disease. So very important group of disorders, everybody, that we usually read in other subjects also. Now, the names are a little, like that. We tend to forget it. So I don't have a mnemonic per se, but this is the way I remembered it during my 3rd year prof in MBBS, everybody. First. Yes. It's a Hindi mnemonic, so please excuse me for the people who do not understand Hindi. I learned it as राम ने वुल्फ को वुल्फ्राम जहर दिया जैर, तो वुल्फ बहरी हो गई बहर और उसका लिवर खराब हो गया लिबर. ओके एवरीबॉडी. राम ने वुल्फ को जहर दिया तो वो बहरी हो गई और उसका लिवर खराब हो गया. सो दिस इज द काइंड ऑफ लाइन आई फॉर्म्ड एंड आई ट्राइड टू रिमेंबर द 4 names, everybody, and along with that the modes of inheritance. Okay, now lastly we made a table in which we have written what are the systemic associations. So as all of us are aware or should be aware that recessive conditions usually have systemic associations. So Wolfram is popularly also written by this acronym, which is DIDMOAD. Okay. Now, what does this mean? These are the systemic associations. Everybody, I hope you have been able to understand yourself. DI for diabetes insipidus. DM for diabetes mellitus. OA for what we are studying, everybody, optic atrophy, and D for deafness. Okay, everybody, that is how I remember DIDMOAD, or you can say 3 Ds, everybody: diabetes insipidus, diabetes mellitus, and deafness. Systemic associations of Wolfram. Systemic associations of Baer, everybody, they can be remembered by the mnemonic ANM. Okay, everybody, ANM workers. So ANM is ataxia, N is nystagmus, and M is mental retardation, MR, everybody. Yes. So these are the three systemic associations of bare hereditary optic neuropathy. Okay. After we've done this simple theoretical knowledge, we have learned it. Let us focus ourselves on the important condition, as I have said, LHON or Leber, everybody. Okay. Now, it is important because it is mitochondrially inherited. So my first question, everybody, mitochondrially inherited diseases are transmitted by your mother or your father, maternal or paternal, everybody. Yes, everybody. All of us know this. Maternally transmitted. Now, what does the genetics say? The transmission is more commonly to the daughter or the son. Does the transmission depend on sex, everybody? Think about it. Genetics, class 12, genetics, everybody. Yes, we know through genetics it is said that it is equally transmitted between all offsprings or each offspring irrespective of sex. But that does not hold true in case of LHON. We say it is more commonly being transmitted to the son. So because it is an exception to the rule, it becomes an MCQ, everybody. Yes. So it is showing us a phenomena that we have again read in class 12th, everybody. Natural selection of a disease. Why? Because females can transmit this disease, maternally transmitted, but it is being more commonly transmitted to the sons or the males, everybody. So without us doing anything, everybody, no treatment, this will slowly eliminate itself. Natural selection of a disease, everybody. Yes. Now, clinical features, we can say. So in clinical features, number one, obviously optic nerve is getting affected, so the patient will experience visual loss. The visual loss is bilateral, hereditary disease, no laterality preference, everybody. And obviously it will be painless. Why do I say obviously it will be painless? Pain is a characteristic of inflammation. Is it inflammatory anywhere? It is hereditary, no inflammation mentioned anywhere, everybody. So bilateral and painless. Number two, everybody, it occurs due to a point mutation. So if it is getting inherited, there is some kind of mutation. So it is point mutation at 11778 codon. So the codon is 11778. Then number three, everybody, when we look at the optic disc, we note some peripapillary telangiectasia. Telangiectatic vessels which are in the peripapillary region. Again and again I have explained, papilla means optic disc, peri means around. So around the optic disc you will see telangiectatic microangiopathy or telangiectatic blood vessels. Yes. Number four, you will see pseudopapillitis. That means when you examine the optic disc, you will feel that there is some swelling or inflammation of the optic disc. But there is actually no swelling. It is just the appearance of swelling. And that is why we are calling it pseudopapillitis. Number five, everybody. Pathognomic sign. Papillomacular nerve fiber bundle dropout. Fancy line with a simple meaning. Everywhere that is the truth, everybody. Papillomacular means optic disc and macula. Nerve fiber dropout. Dropout means loss, everybody. So there is specifically loss of nerve fibers which are present between the macula and the optic disc. Papillomacular nerve fiber bundle dropout. But this is the language used by the authors who have explained this disease. And that is why we need to learn this language, everybody. The meaning is very simple. And lastly, everybody, all of us know it will lead to primary optic atrophy. Yes or no? Because it is hereditary, the last question, if I ask you what is the treatment, obviously I will say no treatment. It is a hereditary disease. Our genetic treatments are still not so refined as to be able to treat the genes, everybody. The gene therapy is still not so developed. So we say no treatment is here possible. Yes. So the clinical features we can learn by the letter P. P for primary optic atrophy, everybody. P for papillomacular bundle nerve fiber dropout. P for pseudopapillitis, peripapillary telangiectasia, point mutation, and painless visual loss, everybody. So I like to say 6 P's of LHON, everybody. I hope we have been able to understand simple stuff, nothing much to understand, to learn basically, everybody. That's all about our very simple topic, yet a very commonly asked topic, LHON, subtopic of hereditary optic neuropathy. Moving on to the next short topic, everybody, toxic or nutritional optic neuropathy. Again, if you run your minds, everybody, we have mentioned this as a cause of central scotoma in part 1 of neuroophthalmology when we were discussing the visual field defects, everybody. Yes. So the name itself is very clear. Optic neuropathy, that it means optic nerve disease is occurring due to some toxic agent or due to some nutritional deficiency. Yes. So what are the causes? Cause number 1 is deficiency of vitamin B1, B2, B6 and B12. So basically you can say vitamin B complex at large. Yes. Secondly, very important cause is methanol poisoning. Clearly remember, I am saying methanol. If we remember pharmacology, what is the treatment of methanol poisoning? Ethanol. If I ask you, though you may be young guys, but still if I ask you what is ethanol, what we drink everybody as form of hard drinks, our whiskeys and beers, that is ethanol. So we are drinking the treatment, everybody. We are not going to get optic neuropathy through that, everybody. Methanol poisoning, please remember. And lastly, everybody, what you should be aware of, pharmacology again, drugs, everybody. So there are some drugs which are oculotoxic, everybody. So what are the drugs? I am giving you a mnemonic. The mnemonic goes by DICE, DICE. Okay, everybody? DICE. D for digoxin. I for isoniazid. C for chloroquine. And E is what I expect all of us to know. Anti-tubercular drug, everybody. Anti-tubercular drug which has side effects related to the eye, everybody. Yes, all of us know that. Ethambutol. Okay, so oculotoxic drug, very important drug, ethambutol, along with the other drugs that I have written in the list for you. These are the important causes of a case of toxic or nutritional optic neuropathy. Now, please remember, even though I had said that toxic optic nutritional optic neuropathy is a cause of central scotoma, but centrocecal scotoma is more common than central scotoma. Okay. Now, what is centrocecal scotoma? If I draw the visual field for you, everybody, this is my visual field. This is the vertical meridian. This is the horizontal meridian. This is the point of image formation as we know from anatomy, fovea. This is my optic disc. Okay, everybody. So a small visual field defect between the optic disc and the macula or the fovea is called centrocecal. Whereas what is central, we already know. We have read it, everybody. We have drawn the diagram. Central is affecting the center. Okay. So both can occur, but as a question, if somebody asks you what is more common, what is the most common visual field defect in toxic or nutritional optic neuropathy, the answer has to be centrocecal scotoma. Yes. Now, what is the treatment, everybody? So the treatment is 1000 units of hydroxycobalamin weekly for 10 weeks. So that is the duration of the treatment. That is the dose of the treatment, everybody. Okay, everybody. I hope there is no confusion in any of this. That's a very small and short and sweet topic for all of you. That is nutritional or toxic optic neuropathy. Now, going back to the list, everybody, of optic atrophy, we have covered optic neuritis, we have covered toxic optic neuropathy, and we have covered hereditary. So we have covered the important topics that lead to primary optic atrophy. Now we move on to an important topic, that is papilledema, everybody, which will lead to secondary optic atrophy. So let's move on to papilledema. Again and again I have said papilla is optic disc. So if we break up the English, it is made up of two words now, everybody. The first is papilla and the second is edema. So what does papilledema become? It becomes edema of optic disc, yes? Or if I call it in simple words, swelling of optic disc. Yes, that is what we think. That is what we answer. But if we answer this, we are absolutely wrong, because we are not integrating our knowledge of a clinical subject with a non-clinical subject. Papilledema we actually have read in anatomy also, everybody. I have given you the clue. Think about it. Papilledema. Papilledema. Where have we read the word? Anatomy. Yes, CSF, cerebrospinal fluid. Whenever there is raised intracranial pressure, that is what leads to papilledema. So without saying that important part, the definition of papilledema, the meaning of papilledema is always incomplete. So if I complete the definition of papilledema, it becomes swelling of optic disc due to raised intracranial pressure. Very important part of our definition. Okay, everybody. So what is papilledema? Due to raised intracranial pressure, swelling in the optic disc. Now, why does it become important? Let's try to understand. We have said the word swelling. I say swelling can be of two types. Basic pathology, if I am talking about, it can be inflammatory or it can be non-inflammatory. Non-inflammatory or hydrostatic passive swelling, everybody. Yes or no? So I ask you, based on the definition now, papilledema, is it having inflammatory swelling or non-inflammatory swelling? Answer is very clear. It is due to raised intracranial pressure. There is no mention of inflammation here. So the swelling is non-inflammatory. Because the swelling is non-inflammatory, can I say this condition will be painless? So I hope you understand every point is linked with every other. If we mug up, we will forget, we will get confused. But if we understand the core ethos of a topic, everybody, everything links with everything else and we are able to remember all this. Yes, I hope we are clear about this. So swelling of optic disc due to raised intracranial pressure, which is painless because it is non-inflammatory. Also remember, everybody, this condition is always bilateral. Yes, when raised ICP is there, it is going to transmit the pressure back to the optic nerve, both the optic nerves rather than only one. Only exception is a syndrome except Foster-Kennedy syndrome. So as an MCQ, please remember it is always bilateral, but there is only a single exception, that is Foster-Kennedy syndrome. So if I revise with you, everybody, this is due to raised intracranial pressure. That is why it is painless and it is always bilateral. That is the take-home point here. Now, if we understand what is papilledema, you ask me, sir, what are the causes of papilledema? I will say, I am not going to tell you. This is a part of your anatomy, everybody. I hope you go back to your anatomy videos and you see the causes of papilledema. Why? Because the causes of papilledema are linked to the flow of cerebrospinal fluid. Whenever there is any cause of increase of CSF pressure, everybody, let's say malignant hypertension or hydrocephalus or a tumor blocking the flow of CSF, everybody, there is bound to be papilledema. Papilledema is not a disease in itself. Papilledema is a sign of a disease, and that condition or that disease is raised intracranial pressure. So I hope you do go back to your anatomy and read the causes there, and let us not duplicate the knowledge here, everybody. Yes? Now, let us understand the etiopathogenesis here, everybody, or the pathogenesis. How does this actually occur? Okay. So, how does the raised ICP, the pressure of CSF, get transmitted to the optic nerve? This gets transmitted because the optic nerve behind the eye, that is the retrobulbar part of the optic nerve, the second, the third and the fourth part of the optic nerve, they have a common meningeal sheath with the brain, everybody. Yes. So the raised ICP gets transmitted along the subarachnoid space to the optic nerve due to this common meningeal sheath. Okay, everybody. So the pathogenesis is that the raised ICP gets transmitted along the subarachnoid space to optic nerve. Okay. In effect, it is causing pressure at the optic nerve head, which is leading to blockage of exoplasmic transport. Exoplasmic transport, a simple word will be conduction, everybody. Nerve conduction is getting stopped, which is leading to stasis. Now, whenever we hear the word stasis, everybody, What do we think? We should think two things. Basic pathology, everybody. Stasis will lead to what, everybody? Stasis will lead to fluid coming out. So it will lead to extracellular edema. And it will lead to venous congestion. Yes? So this is the basic pathogenesis. Because of the common meningeal sheath, everybody, the pressure is getting transmitted and leading to two sets of signs, I can say, or two sets of effects, everybody. If I say extracellular edema, we can say mechanical signs. If we say venous congestion, we can say, everybody, what? Vascular signs. Yes, that's how easy it is, everybody. So two types of signs or two sets of signs I am saying. So let's discuss the science along with the etiopathogenesis so that we understand the science right here, right now. Mechanical sign. Extracellular edema is occurring. Extracellular edema will lead to what, everybody? Optic disc swelling. Optic disc swelling means, everybody, I have told you in optic atrophy classification, swelling will lead to blurring of disc margins. So if you ask me, sir, what is the earliest sign? I will say very gladly, blurring of disc margins. I hope we are pretty clear about this. Yes. Secondly, when we look at the optic disc, everybody, through our ophthalmoscopes, because of swelling, everybody, anything which is swollen will appear fat, mota. That means it will appear raised, everybody. Yes. So I will say there will be elevation of optic disc. When we visualize it, it will appear elevated towards us, anteriorly elevated, everybody. Thirdly, there is a sign which is called as Peyton's lines. What is Peyton's lines? The extracellular fluid which is there in the optic disc is also leaking out into the surrounding peripapillary area. What is there in the peripapillary area? Everybody, again, look at my hand if you don't understand. This is the optic disc. What is the peripapillary area? It is the retina. It is the choroid, everybody. Yes. So there will be some edema in the retina and the choroid, which will lead to some kind of folds, and those are known as Peyton's lines. If you don't understand, think as if you have just washed a shirt of yours, everybody. Yes. And you have wrung it out. So when you wash the shirt, due to the fibers of the cloth, everybody, which have accumulated fluid, you get some folds in the cloth, everybody. Yes. So because there is fluid in the retina and the choroid, it will develop some folds into it, which will be visible as fine lines, everybody. So let me first write and then I will show you the image. Retinochoroidal folds. Okay, I hope you've been able to understand the concept so that you appreciate the image, everybody. Let's see this image on the screen. You can see the optic disc here. You can see the blurring of disc margins. Along with that, in these two arrows which I am drawing now, you can see some lines which are occurring due to retinochoroidal folds, and these are known as Peyton's lines. Okay. Theoretical question has been asked, I think, in 2017 DNB examination, when that used to occur separately, everybody. Image-based questions are not far away, so I hope you understand. Very easy photo to be able to look at. Going back, everybody. Fourth sign, mechanical sign. In chronic cases, due to continuous swelling of the optic disc, the anterior part, everybody, of the optic nerve, that is the optic disc, that will become swollen. The posterior part will be thin. So it will give us a appearance of champagne cork. I hope you understand. Champagne cork looks like this, with a large top, and as it goes inside the bottle, it narrows. So this is my optic nerve retrobulbar. This is my optic disc, which has become enlarged, everybody. So that is why it is leading to a champagne cork appearance in chronic cases. Okay. Now, based on this point, everybody, if you have been able to understand, if I ask you a question, what is the visual field defect? Simple question, everybody, if you understand. We have already answered this in part 1 neuroophthalmology. Again, everybody, we are discussing the same topic. It's just a different part of that topic, everybody. Yes, the optic disc has become enlarged. Optic disc has become enlarged, leading to champagne cork. Focus on the line. Optic disc has become enlarged. Optic disc is known as, yes, you know the answer, everybody. Enlargement of blind spot. Okay. So as I said earlier in visual pathway and visual field defects, even though this is a visual field defect, this is not clinically significant because it is not appreciated by the patient. The patient does not report any loss of vision due to this, everybody. Okay. So theoretically, we should know enlargement of blind spot. Why? How? I have explained to you here. Okay. Now, these are the mechanical signs. Now, going back, everybody, what will be the vascular signs? Vascular signs are very easy, everybody. There will be congestion. Congestion will lead to what, everybody? Hyperemia of the disc. Hyperemia of the disc means the disc will appear more reddish, more orangish, everybody. Yes. Secondly, everybody, what can occur, everybody? What can occur? We have already read it under the table. Macular star appearance. Thirdly, due to the excessive pressure being radiated back, there is loss of venous pulsations at optic disc. There is a controversy. Some textbooks say that loss of venous pulsations at the optic disc is the earliest sign of papilledema. But that is not the true answer because venous pulsations are absent in a percentage of general population also. So even if you are a normal optic nerve, even if you have a normal optic disc, still venous pulsations may be absent. So a sign which is already absent in a portion of the normal population cannot be a diagnostic sign of a disease condition like papilledema. So I hope it is self-explanatory. Please don't get confused. The earliest sign, as I have explained, is blurring of disc margins. There is no controversy. There is no confusion in this, everybody. Yes, I hope we are clear. These are the important signs of a case of papilledema, very important condition. Now, we know what is papilledema. We know the condition. We know the signs. But what about the symptoms, everybody? So if I ask you the symptoms, am I actually asking you the symptoms of papilledema? No. Why? Again, I'll reiterate my line. Papilledema is not the disease is raised intracranial pressure. So when I'm asking you the symptoms, what the patient is presenting with, symptoms of raised intracranial pressure. Yes or no? Yes. So what are the symptoms of papilledema or in fact raised intracranial pressure? Earliest. This is a viva voce question everybody asked in every posting in medicine, everybody. Yes? Headache. Severe headache along with projectile vomiting. I know as soon as we heard headache with projectile vomiting, we said, we have heard this. Yes, we have heard this. We have heard this numerous times, everybody. Please remember the headache is worse in morning. Classically, the patient says, when I get up, my headache is the worst. Okay. It is kind of a vicious cycle. You can say the headache keeps on increasing. When it reaches its nadir, we have a bout of projectile vomiting. Along with the vomiting, the headache disappears. Then again, the headache increases. Again, it reaches the nadir. Again, a projectile vomiting, everybody. Yes. So headache, vomiting. That is the cycle the patient keeps undergoing, everybody. Next, everybody. I ask the patient, what about your vision? You have some vision loss, yes or no? If you have some vision loss, do you have a painless vision loss or a painful? The answer to this we already know. Because it is non-inflammatory condition, everybody, it will be painless. But if it is painless, is it sudden or is it gradual? So what is the answer? The patient should complain of gradual painless loss of vision. Yes, that is what we have read in our textbooks. If we have gradual painless loss of vision, I am writing LOV as loss of vision. But this is absolutely incorrect. I have purposely written it and then crossed it because a lot of students make this mistake. What instead I am writing, the vision the patient will say is absolutely normal. You can take my vision will be 6/6. Why is that so, everybody? Think about it again, everybody. Think about it again. Optic disc is known as blind spot. The answer is there. Optic disc is known as blind spot. This is a condition which is affecting only the blind spot. Can I make you more blind from an area where you are actually blind? क्या मैं अंधे को और अंधा कर सकता हूँ? I hope you understand the answer. But then the question comes into your mind, why do some of our textbooks write gradual painless loss of vision? They skip a step basically. So what am I trying to say? That papilledema, vision is normal. But papilledema leads to the topic that we are reading, actually secondary optic atrophy. Optic atrophy means optic nerve is not functioning. So that will lead to gradual painless loss of vision. So the textbooks have just missed a step. When they write gradual painless loss of vision, they are writing that loss of vision is due to the optic atrophy, which is due to papilledema. But you can't attribute that loss of vision due to papilledema. Yes? So if the question comes, point blank answer, no visual loss. I hope you get this clear in your heads. Okay? Now, similar to vision, everybody, there is normal pupillary reaction. Only the smallest part of the optic nerve is affected, and that too only edema, everybody. Rest of the optic nerve is functional. Even though there is blockage of exoplasmic transport, it is slow, but the conduction is occurring slowly also. So when we test the pupil, the pupils will be able to constrict. Normal pupillary reactions. Next, some patients complain of horizontal diplopia. Diplopia means double vision. Horizontal means while looking to the right or to the left, due to associated sixth cranial nerve palsy. Okay, everybody. And lastly, that is, you can say, a very important sign. Some patients come to us complaining of this word, hemaurosis fugax. Now, what is the meaning of hemaurosis, everybody? Hemaurosis fugax. Yes, we have heard this. Yes, the answer is transient. Transient visual loss. Usually, we think about TIAs when we hear hemaurosis fugax. TIAs means transient ischemic attacks, everybody. Dil ka daura, heart, stroke, everybody. Yes? Am I clear? But if a patient with papilledema is complaining of it, our diagnosis becomes much more certain. The patient is saying, in effect, that my vision is normal if you record, but I experience transient episodes of blackness where I lose my vision, and that vision comes back in 5-10 seconds, everybody. When that episode is going to occur, I don't know. Will it occur tomorrow? I don't know. Will it occur after a year? I don't know. But yes, such kind of episodes, the patient has a history of. Yes, transient visual loss. The key word is transient, everybody. Whenever it is there, it is only transient. It regains back. Am I clear to everybody? Done? And that is all about our very special and very important topic, everybody, papilledema. So now, before I finish, some of you may want to ask me, sir, what is the treatment of papilledema? I will say I don't know. Why I don't know? Because I am only diagnosing papilledema to confirm whether the ICP is raised or not. The patient needs to be diagnosed for the cause of raised ICP. And based on the cause of raised ICP, we will be able to treat the case. Okay, everybody? So, how does it hold? The patient comes to pediatrics department or general surgery or general medicine, then gets referred to ophthalmology to confirm whether the patient has raised ICP or not based on papilledema finding yes or papilledema finding no. And then the patient gets referred back, everybody, to get treated. I hope you understand. Okay. Lastly, I'm going to show you some photographs, everybody. This is called Frissen's grading scale for papilledema. Okay. Rather than going in depth into the grading, everybody, I don't think anybody is going to ask you that. I will explain you the images here. What do you see in this image, everybody? We see a lot of hemorrhages, everybody, splinter hemorrhages. Okay, a sign, a vascular sign, everybody. In the second photograph, if we see carefully, we are able to see that there is a loss of blurring off or loss of disc margins. Yes, in this area, everybody. You can't see the disc margins, everybody. Okay, so this is called a C-shaped halo, blurring of disc margins. In this image, you see that all the disc margins are lost. We can't see any disc margin at all. Yes, no disc margin. Here what we see that a major blood vessel, see, I am tracing a major blood vessel, it is coming out, then it gets lost, everybody. So loss of a major blood vessel on the optic disc surface. And lastly, we see, everybody, we can't see any blood vessel on the disc surface, everybody. Okay, so this is a grading scheme, everybody, starting with grade 1 to grade 5, and it is called as Frissen's grade. If I number the grades for you, this will be grade 1, C-shaped halo. This will be grade 2, complete obliteration or loss of blurring of disc margins. This will be grade 4, in which we have lost a major blood vessel over the disc surface. Lost means we can't see. Yes. And lastly, this will be grade 5, everybody, where there is loss of all the blood vessels over the disc surface. I can't see a small or a large blood vessel, nothing over the disc surface. Okay. I hope we are clear about the images. What is more important is that you are able to identify the image to papilledema rather than grading it, and you are able to remember the name Frissen's grading scale. Okay, everybody. And that ends my papilledema group. Moving on to the last condition, everybody, under optic atrophy. Anterior ischemic optic neuropathy. The name itself is pretty clear, everybody. It is an optic neuropathy which is affecting only the anterior part of the optic nerve, and that is the optic disc, and it is ischemic. That means it is occurring due to some interference with the blood supply, everybody. Okay? So anterior ischemic optic neuropathy. This can be of two types, as we see in the table below us. The first type is known as arthritic AION, and the second is known as non-arthritic. Arthritic and non-arthritic names are based on the fact that arthritic AION is due to a condition which is called as giant cell arteritis. Giant cell arteritis is a type of vasculitis, everybody, okay, where the inflammation of temporal artery is mainly there, everybody. Whereas non-arthritic has nothing to do with vasculitis or inflammation, and it is due to occlusion of the blood supply, that is the short posterior ciliary artery, SPCA. Please remember the anatomy of the eye, the first topic, the first chapter that we have read per se in this video series, everybody, and the blood supply of each part, everybody. Yes? Now, let's first focus on arthritic AION. Whenever arthritic AION occurs, you have to remember three things. Number one, it will present with severe visual loss. So the patient's vision will be less than 6/60. There will be something like a pain or amaurosis fugax along with that, and it will be bilateral. Okay. So as far as the initial examination of the patient or the history taking is concerned, that is what we will end up noting. Vision loss severe along with some premonitory symptoms like pain and amaurosis fugax and bilaterality. All these will be opposite in non-arthritic AION, everybody. Non-arthritic will have moderate visual loss. The vision will be greater than 6/60. This will be absent. There will be no pain, no other symptom associated with it, and it will usually be unilateral. Okay, everybody. So based on the initial examination and the workup of the patient, you somewhere know whether it is arthritic or non-arthritic. Now, you examine the patient on your slit lamp. You see the optic disc, everybody. If the optic disc is pale, okay, everybody, as we saw in primary optic atrophy, pale, whitey, pale or pale yellow, everybody, it will be arthritic AION. If it is hyperemic, everybody, hyperemic means more red, like we saw in papilledema, everybody, it will be non-arthritic. So based on your initial workup, you can see the optic disc and confirm your diagnosis. Now, everybody, please remember that the treatment of arthritic AION, because it is a form of vasculitis, that is the cause, we need to cut the inflammation, and that is why the treatment of corticosteroids, or we can use aspirin also. Whereas in non-arthritic AION, we usually say there is no treatment, but as an experimental treatment, it has been postulated that a combination of levodopa, carbidopa may be useful. Again, I am saying may be useful. It is postulated. It is not used. Usually we say there is no treatment. If you remember AION, we had read, everybody, altitudinal visual field defects. These altitudinal visual field defects will be occurring in both, everybody, in arthritic AION as well as non-arthritic AION. Okay. Lastly, please remember that other conditions are associated with arthritic AION which lead towards vasculitis, like, everybody, temporal artery non-pulsatile, there is some headache, etc., etc. Whereas all the conditions which can lead to vascular blockage, like hypertension, CVDs, diabetes, hyperlipidemia, they will be associated with non-arthritic AION. Am I clear? They have taught to you in a pre-formed table format because this is a very rarely asked topic. Nonetheless, it can be asked, and that's why I've tried to just make you learn this, everybody. Nothing much to understand in this. Yes, that's all about our Third subtopic, everybody, optic atrophy. Along with that, we do a very small topic, everybody, that is congenital anomalies of optic disc, to be able to answer all questions on optic disc diseases. Okay. So in congenital anomalies of optic disc, everybody, we will read two important conditions. The first condition you can see on your screen. Let's see this through an image and then try to answer it, everybody. Okay. What is the similarity between the two images we see, everybody? In both the images we see, in the center there is a empty area, white area. Okay. And in the periphery there is radiation. Okay. Spoke like wheels, everybody. Okay. So we can see all the blood vessels. There is no blood vessel visible in the center. All the blood vessels are exiting from the periphery, as if making a spoke like appearance. This flower is called as morning glory flower, and that is why this condition of the optic disc gets the name morning glory syndrome. I hope we are clear between the similarity of the shape of the flower and how the flower appearance and the shape of our optic disc. Okay. This is a congenital malformation of the optic disc, everybody. It is due to, that is what we want to understand, congenital unilateral, again an important word, malformation of optic disc, which is due to three things. The third we have already done, axial retro displacement. That means behind, everybody, of optic nerve. The optic nerve goes behind. Apart from that, there are two main causes, everybody. A peripapillary around the optic disc scleral defect. So basically the retina and the choroid have lost its support. So that is why the optic disc is able to retro displace itself. And there is absence of lamina cribrosa. Am I making myself very clear, everybody? Yes, the appearance we already know. We have seen bow-like appearance, everybody, or spoke-like wheel appearance, everybody. Morning glory syndrome. Done? Now, move on to the next condition, everybody. This condition is known as myelinated nerve fibers. We have an optic disc, and along the optic disc, we have some whitish radiations, everybody. Okay? Some whitish radiations. So, why is this and what is this, everybody? Again, going back to part 1 of neuro-ophthalmology, where we had read the optic nerve anatomy, everybody, we had said that the optic disc is non-myelinated. Myelination is acquired in the intraorbital part of the optic nerve. But if the retinal nerve fibers carry the myelination intraocularly, giving the appearance of whitish radiation, we call it myelinated nerve fibers. As simple as that. There is no visual loss. So this is just something that you can see, that you can write down as a diagnosis, but it has no visual consequences. This is just a congenital condition, myelinated nerve fibers. Right, guys? That's all about our optic atrophy. Let us recap optic atrophy in a brief, everybody. Optic atrophy is of three types: primary, secondary, and consecutive. Primary without any cause. Secondary due to disease of optic disc itself, swelling of optic disc. Consecutive due to disease of retina. Yes. Then based on this, we read optic neuritis. Optic neuritis is of three types, everybody. Papillitis, inflammation of only the optic disc. Retrobulbar, second, third, fourth, behind, everybody. And neuroretinitis, macula plus optic disc, everybody. We read the clinical features of optic neuritis as though Kapmar, 2C, 2U, 2P, U for unilateral visual loss. Important point, and M for Marcus gun pupil, that is the earliest sign. The treatment in ONTT trial, where steroids need to be given first IV and then oral. Hereditary, four important conditions: Jair, Baer, Wolfram, and Lieber. Lieber is mitochondrial. Please remember the 6 P's. It is painless, peripapillary, pseudopapillitis, papillomacular bundle dropout. Then nutritional or toxic. The cause is DICE, methanol poisoning, and the fact that centrocecal scotoma is more common than central scotoma. We read papilledema, very important condition, where we need to remember raised intracranial pressure. That is why it is painless. There is no visual loss, and all the important signs that we read along with it. And lastly, we read AION and the congenital malformations. Very easy topics to remember. I hope you have a recap of the optic atrophy, part 3 neuro ophthalmology done.